Hello everyone, this is Dr. Sultan Moinuddin Shaukat Ali. I am MD and DNB in radio diagnosis. I have completed my radiology from SAIT GSMC and KEM Hospital, Mumbai. I am a 14 gold medalist. Now, today we are going to see an interesting topic in radiology, which is gallbladder and biliary imaging. In this lecture, I would speak on need-based approach, that is, all important questions from need point of view which are asked on this important topic, that is biliary imaging and gallbladder. At the same time, I would also discuss the important points which are to be kept in mind when when the questions are asked about gallbladder or biliary imaging. There are many instances where you would be having questions which are interlinked, that is questions from medicine and surgery which merges with radiology, and that is where we'll be discussing about the case scenarios also. So without any delay, let us begin. So before I start, I'll always start with the basic concepts so that the things are crystal clear and it does not create any problem. So the organ which we are going to image is the biliary system and the gallbladder. So this is liver. Now, few important question. Liver is the largest gland of the body. Important question from physiology point of view. Liver is covered by a capsule which is called Gleason's capsule. Again, important question from anatomy. Now, we have a right hepatic duct here. We have left hepatic duct here. So, both of this, they come together to form common hepatic duct. Important. Here there lies gallbladder. Gallbladder connects to the common hepatic duct with the help of cystic duct, and there is formation of common bile duct, CBD. So we have right hepatic duct, we have right hepatic duct, we have left hepatic duct, we have cystic duct, we have gallbladder, and then we have common bile duct. Now, furthermore, common bile duct merges with pancreatic duct to form pancreaticobiliary duct, which then opens in second part of duodenum. Important, it opens in second part of duodenum, and the opening is major duodenal papillae. This opening is called major duodenal papillae. And it is guarded by a special sphincter which is called sphincter of Oddi. So all these are the basic anatomy questions. In this session or in this lecture, what we are going to focus is imaging about gallbladder and imaging the biliary tract. So I won't go into heavy details of the subject. We'll just discuss all the important concepts which are asked in NEET. So let us begin with. So initially, first thing which you should know is what are the modalities which we use in order to image the hepatobiliary system. So most important modalities being X-ray, the basic modality which is used, ultrasound, that is USG or sonography, next is CT scan, MR in the form of MRCP, that is magnetic resonance cholangiopancreatography, MRCP, T-tube cholangiography, ERCP, that is endoscopic retrograde cholangiopancreatography, cholangiopancreatography. Okay, so that is ERCP. Now, I want you all to remember one more important modality, and that is why I have not written I have not typed it here. It is HIDA scan. HIDA scan. So HIDA scan is a nuclear scan, which is again very important. Few important questions which are asked from HIDA scan, I'll be telling you once we come to HIDA scan. Okay. So these are the modalities, note them down. Now we come to gallstones. The first and foremost very important pathology which is seen in gallbladder. You all know that surgery mnemonic which we say fat, fertile, female, 40. So 4 F's. So if you have fat, you have a female who is fertile of the age of 40. So that increases the chances of having gallstones. So you should always look for the history. So there are 3 kinds of questions which you can get in exams. Number 1, you can get a direct clinical history and you can be asked what the diagnosis is. Number 2, you might get history and along with it there is radiological finding or images and you have to interpret those images, and that is how the diagnosis can be achieved. Based on this, the questions can be asked. Or number 3, you might be given history, you might be given a radiological image, and then you might be asked what to do next, or based on that image, the questions. So let us start with gallstones. So we know that these are stones within the gallbladder. They can be single or they can be multiple depending upon the etiology. Now, very important is how do we, let us start with the first point of radiology, which is an applied anatomy. How do we differentiate? Suppose you have a plain radiograph of the abdomen and you see that there is a stone. So on X-ray, remember that only 10% of stones can be seen. That is, only 10% are radio opaque, whereas 90% of stones are radiolucent. Very important question. 90% of the stones are radiolucent on X-ray. Now, suppose in case you are able to see the stone, that is, stone is within the 10% category, and you are able to see the stone on the abdominal X-ray. Now, in this case, you have to differentiate if it's a renal cal versus if it's a cal within GB. So, how do you differentiate? So, in case of lateral X-ray, the gallstone do not overlap spine. So, I'll show you what does this thing mean. So, now let us see the radiographs. So, this is an X-ray image and you are able to see here this radio opaque. So, when we say radio opaque in X-ray, that means they should be white. White means they are radio opaque. So, you can see the bones. The bones are also radio opaque. You can see this iliac bone. Bone is radio opaque. Similarly, the vertebrae, they are radio opaque. Okay. So, radio opaque means they are bright. Now, similarly, you can see here there is a stone. So, remember all stones, bones and calcification are bright on X-ray. Remember, stones, bones, calcifications are bright on X-ray. Now, you have to differentiate whether this stone, this is AP view of the X-ray, that is anteroposterior view. You have to differentiate if it is a gallstone versus versus renal stone. So, you have to take a lateral view. So, here this is the lateral view, and on lateral view you can see this is spine and this is the stone, and the stone does not overlap the spine. It is separate from the spine. That means it is a gallstone and it is not a renal stone. Okay. Now let us move ahead. Okay. Now this is again a very important question which is asked in Neet. They can directly give this as an image based question and ask you to identify. So you can see here this is AP radiograph of the abdomen and you are able to see calcification along the GB wall. So what is this? This is called porcelain GB. Porcelain GB. So porcelain GB is seen as calcification in GB wall. And very important, calcification is seen bright on chest radiograph. Now again, a very important physics concept which I would like to tell you here is that, remember, CT scan is also based on X-ray principles. So even on CT, bones, comma, calcification would be bright. Bones, calcification, and radio opaque stones, the stones which are radio opaque, they would be bright. Okay, these are important fundas when it comes to CT scan also. So even on CT scan, you will have the wall of gallbladder which is bright in case of porcelain GB. Now, one very important point which you need to remember here when it comes to porcelain GB is that it's a pre-malignant condition. So whenever you have porcelain GB, you have to compulsorily go for cholecystectomy. Okay. Now let us move ahead. Coming to ultrasound. So ultrasound is one of the very important modality which is used for imaging gallbladder. Now here, this is how the ultrasound image is seen. So you have a sector. So there is a probe which is kept on the abdomen and the image is obtained in the form of sector, and you will have, this is called grayscale image. This is called grayscale image. And here you are able to very nicely see this is gallbladder. So what is gallbladder filled with? Gallbladder is filled with bile. So what is bile? Bile is a fluid. Remember, routine fluids on ultrasonography, they are anechoic. What do you mean by anechoic? Anechoic is nothing but they are dark. So you can see that this is completely dark. That means this is filled with fluid, that is bile. Okay. Similarly, you would see that the biliary radicals or the blood vessels would also be dark because it is filled with fluid. Okay. Similarly, you will find that the IVC or aorta would also be dark, which would be anechoic. Okay. Now, that is basic concepts of ultrasound. Now, what you need to know is that the lumen of the gallbladder should be completely anechoic. Okay. Now, a very important concept when you do ultrasound is that you need minimum 6 hours of fasting. Basic physiology question which is often asked based on this. Why do you need 6 hours of fasting? Because if fatty food is taken, GB would contract, which is called cholagogue and choleretic action because of fatty food. So in order to avoid that, you need 6 hours of fasting, and then you have to scan it in the subcostal or intercostal region. Now, few important points which I would like you to remember is that GB wall thickness is less than 3 mm. If it is more than 3 mm, then you can suspect that this is a case of acute cholecystitis. Okay. So here the basic funda out of this slide which you have to remember is that on ultrasound, GB lumen should be completely anechoic as it is filled with fluid. There should be no content within it. Okay, with this concept, let us move ahead. So here I have shown you 3 images. Okay. So if we see image 1, you are able to see that this is gallbladder. Within the gallbladder, you are able to see that there is a hyperechoic. What do you mean by hyperechoic? Bright. So you are able to see hyperechoic content, which is bright content within the lumen of gallbladder, and you are able to see that beyond this, are you able to see this black line? Just posterior or just below the hyperechoic area. Similarly, that can be very nicely seen in this image, which is in another case. So here you see that this is gallbladder. You are able to see a hyperechoic content within the gallbladder, and just beyond this, you are able to see there is a dense shadowing or dense hypoechoic area. So this, or anechoic area, which is called shadowing. So this phenomenon, this physical phenomenon is called posterior acoustic shadowing. So what do you mean by posterior acoustic shadowing? When ultrasound passes, suppose this is a stone, when ultrasound passes and reaches the stone, this surface is too hard and ultrasound passes through the nearby structures. However, it doesn't pass through this, and as a result, there is an area of shadowing which occurs beyond this stone, and this is called posterior acoustic shadowing. So, very important. Where else will you see posterior acoustic shadowing? It will be seen anywhere where there is stone or calcification. Okay. So, where else can you see this? You can also see this in case of renal calculi. Very important question. So, you can directly get question on this, that they might show you the image of gallbladder, they might show you this posterior acoustic shadowing, and they might ask you where else do we see it. So, we also see it in cases of renal calculi. Okay. Now, let us see the third image which is left. So, here you are able to see this is again a gallbladder, and you are able to see multiple tiny hyperechoic stones within the gallbladder, and you can see the multiple shadowings which arises out of each of this. So, these are multiple calculi, multiple stones or multiple calculi. Okay. Now, what is an important question which can be asked on this basis? So, remember, usually if you see solitary stones, what is the composition of solitary stones? Cholesterol. So, cholesterol stones are solitary. Very important question. This is a question from pathology and surgery. Now, based on radiology. Now, one other important question. If you see multiple stones, what is the second thing which you look for? So, if you have multiple stones, you look for hemolytic anemia. Important question. So, you will look for hemolytic anemia. So, you will look for sickle cell or hereditary spherocytosis. So, all this can lead to multiple pigmented calculi. Of course, you won't be able to see the pigments on ultrasound, but multiple pigmented calculi, very important cause, hemolytic anemia. Again, a very important correlation from pathology. Now, with this in our brain, let us move ahead. Okay. Now, look at this image. Again, this is an ultrasound image. You are able to see this is a gallbladder here, and we are able to see hyperechoic content within the gallbladder. But very important, if you compare it with the previous slide, these are all dependent. These are all dependent. This is in the dependent area. If you see here, this is in the non-dependent area. And very important, if you ask the patient to move, it does not move. It does not move with the patient movement. So, if you ask the patient who is supine to be in the lateral decube, and then again if you see in case of stone, it should change the position. The stones are mobile, but in this case these lesions are not mobile, and these are GB polyps. Very important. These are GB polyps. Okay, so this is how the polyps appear. Again, sometimes you can have GB polyposis. So, you can have multiple polyps within GB. They give such an appearance. Okay. And one very important sign which I have told you is that GB polyps, they do not move when the patient is moved, number one. Number two, they do not show shadowing. They do not give posterior acoustic shadowing. So, there is no posterior acoustic shadowing. Okay. Very important question which is often asked based on this. Okay. So, you can be asked image based questions, you can be asked direct the image characteristic question. Okay. Now, we will move further. If a special sign, See, sometimes you might have a cal, and within this cal there might be air. Very important. And the trapped air gives a specific sign which is called Mercedes-Benz sign. Very important question. Recently it was asked in Neet. Mercedes-Benz sign is seen in, and it is due to air which is captured within the calculi. So now this is a very important question. Now when it comes to GB calculi, we already know that 90% of them, they are radiolucent. So if they are lucent, that means you cannot diagnose them on X-ray. X-ray is a bad modality for diagnosing. So in all of these cases, the investigation of choice is ultrasound. So very important, the second statement is a VIP statement. Investigation of choice for gallstones is ultrasound. And second important point is that acoustic shadowing is also seen in renal stones. We have discussed this point even before. So USG is the investigation of choice for gallstones for GB calculi. Okay, with this, let us move ahead. Okay, so now firstly, I want you all to identify what investigation this is, and then what radiological image this is, and then we'll jump to the various sign. Okay, so first let us try to identify, is it ultrasound? Is it USG? Answer is no, this is not USG, because how does USG image appear? It is in quadrant and you don't see this bones as this bright. Okay, here you are able to see the anterior structure as well as posterior structure very nicely, and you are able to see that this is sectional imaging. This is cross section. Okay, this is cross section. So when it comes to cross section, this is either CT or this is MR. Now you have to differentiate whether this is CT or MR. Now in initial slides, if you remember, I have told you that on CT, as it is based on principle of X-rays, you see calcification and bones are bright. So here, can you see this bone? These are the ribs. The ribs are all bright. The vertebral bone is also bright. That means what investigation is this? This is CT scan. This is CT scan. Okay. Next question is whether this is plain CT or a contrast CT. Okay, whether it's plain or versus contrast. So in that cases, you have to see this aorta. Look at this aorta, and you see the aorta is not showing any contrast within it. So no IV contrast is given here. But if you look at bowel loops, yes, there is contrast within the bowel loops. So that means oral contrast is given, but IV contrast is not given in this case. And now we see what we are supposed to see here. You are able to see here, this is GB, this is the region of gallbladder, and this is a gallstone which is lucent here, probably it is not seen. So lucent stones cannot be seen even on CT. Okay, but what you are able to see is a air. Very important. Again, you know that how does air look on X-ray? Air looks dark on X-ray. CT is based on X-ray principles. So air on CT is also dark. So you are able to see the Mercedes-Benz sign, which is formed by the air which is trapped within the gallstone. Okay, okay, with this let us move ahead. Now we have discussed about gallstones, we have discussed about GB polyps. Now a third very important question which is asked from ultrasound of GB is this, what we are going to discuss now. So if you look here, this is the GB. This is the image within the sector. So this is an ultrasound image again. Okay. Now if you see very carefully, you will be able to see such structures. So you will be able to see that there is such an area, and then beyond this you find such artifacts. Okay, so how do these artifacts look like? They look like comet tail. So I'll show you here. Are you able to see here? This So these are called comet tail artifacts. Comet tail artifacts. Very important question. Comet tail artifacts are classically seen in adenomyomatosis of GB. VIP question. Okay. Compulsorily you should know this. This question will take you ahead of others if you know it. Okay. अब थोड़ा और सीखेंगे. So we are going to upgrade ourselves. So we have seen ultrasound image, we have seen how CT appearances look like. Now let us see this and analyze this image. So is it ultrasound image? Let us identify the scan first. Is it ultrasound image? Answer is no, this is not ultrasound because it's not a sector image. Next is you are able to see the anterior aspect as well as posterior aspect very clearly. It's a sectional imaging. It's a section. So this is either CT versus MR. So are you able to see the bones which are dark? Okay. So this is a case of MR. This is MR imaging. Okay. And now on this, are you able to see this? This is GB. This is GB. And in GB, you are able to see multiple T2 hyperintense cystic areas within it. So this is called pearl necklace appearance or string of bead appearance, string of pearl appearance, string of pearl appearance, which is seen in case of adenomyomatosis on MRI. So very important, on MRI, adenomyomatosis gives a special appearance which is called string of pearls appearance or string of bead appearance. Okay. Okay. Now we have seen about adenomyomatosis. Now a third important pathology. So suppose if a patient who is a known case of gallstone, she comes to you with acute pain in the right hypochondriac region, and if you press that area and that is very tender, what is that sign called? If there is pain in that region, this is called Murphy's sign. So if there is pain in RHC, this is Murphy's sign. So surgery question, Murphy's sign. Okay. Murphy's sign is one of the important sign of acute cholecystitis. So when you have on ultrasound, you are able to see that this is gallbladder, this is the stone which is showing posterior acoustic shadowing, there is sludge within GB, and very important, I want you to focus on two important findings. If you see the wall of gallbladder, it is thickened. So this is the thing which I told you in my third slide, that if the wall is more than 3 mm, it is a very important sign of acute cholecystitis. Again, here you are able to see that the wall of GB is thickened more than 3 mm. Okay, this is thickened wall. And what is this? This is the Doppler study. So this is called color box. So if we put color box and you are able to see, this is the vascularity within the wall. The vascularity in the wall has increased. All these are the signs of acute cholecystitis. Acute cholecystitis. So in case of acute cholecystitis on ultrasound, what are important findings? Increased wall thickness. And second important sign we have seen is increased vascularity. Okay, very important. But now the question which I am asking is very important. What is the investigation of choice for acute cholecystitis? Best investigation for acute cholecystitis? The answer is HIDA scan. Okay, so best investigation for acute cholecystitis. Okay, now what is HIDA scan? So HIDA stands for hepatobiliary immunodiacetic acid scan is an imaging procedure which is used to diagnose hepatobiliary disorders, and in which this is also called hepatobiliary scintigraphy technique, where a radioactive tracer is injected into vein of the arm, and then after IV injection of the tracer we take various images, and this is how normal HIDA scan looks like. So you can be shown image of this and can be asked what this imaging modality is. This is a case of, this is HIDA scan. So you can see the again fundamentals. That is why we started with the basics. So you can see the right hepatic duct, the left hepatic duct, the common hepatic duct, the gallbladder and the common bile duct. So you will see that the tracer is excreted from the hepatic ducts into GB and then via CBD into the duodenum and then into the small bowels. So this is how the tracer is excreted. So now, very important, I will show you a pathological case. Let us see this image. So even after waiting, if you do not see the GB, GB is not seen, but you are able to see the contrast within the bowel loops, in the bowels. So HIDA scan, GB not seen. This is a very important sign of acute cholecystitis. Now, this question was asked in recent Neet, where GB is not seen in case of acute cholecystitis. Now, one more important question which is based on similar principle. So, if you have understood this concept of imaging, you will also understand this question which is often asked in exams. Again, it's a pediatric question, but of course it has roots in radiology. So, I'll discuss it. In case of biliary atresia, so what do you mean by atresia? See, normally biliary canals should have a central lumen. Okay, if it is atretic, the lumen is not there. There is no lumen. They looks like a triangle, and hence this is called triangular cord sign. On ultrasound, this is called triangular cord sign. Again, it's a very important question. Triangular cord sign on ultrasound is shown by biliary atresia. Now coming to HIDA scan in biliary atresia, as there is no lumen, will the contrast be excreted down? Answer is no. So again on biliary atresia, you will see that the contrast stays up in liver, but it's not excreted in GB, not excreted via CBD, and you will see that in biliary atresia, there is no contrast, sorry, no radio tracer, no tracer in bowels. A very important sign in case of biliary atresia is that you do not see the radio tracer within the bowel loops. Important. Chalo, let us move ahead. So, let us see how much can you apply what we have learned. So, here you see that this is GB ultrasound image. You are able to see that the wall is thickened, and suppose if there is cal here, then this is a case of acute calculus cholecystitis, GB wall thickening. Now again, same case where you can do the CT image. So again, you are able to see that the bones which are bright, this is a cross sectional imaging, and you are able to see that the wall of GB is thickened. So if walls of GB is thickened, again this is a very important sign of acute cholecystitis. Okay, chalo, let us move ahead. Okay, now you have enjoyed acute cholecystitis. Now we'll come to a very important another sign in radiology which can be a potential question. This can be a potential question. We call it as WES complex or wall. This is a perspective new question. Wall echo shadow complex. So here what happens? Normally you see GB like this. Normally you see GB like this. Correct? This is the lumen of GB. This is how normal GB should look like. But in these cases, you see GB would look like this. A shrunken GB, and this is seen on ultrasound. Okay, this is on ultrasound. You see that the GB is shrunken. You see a hyperechoic area here. Then you see another lining. And beyond this, you see shadowing, a dense shadowing. There is no lumen. So you are not able to see the wall, the lumen separately, and you are feeling as if the entire thing is calcified. And this is called wall echo shadow complex. It's a very important sign of chronic calculus cholecystitis. Very important question. Okay. So this is a perspective new question. I'll show you the image. So look here, you are able to see the GB lumen is not seen separate. You are able to see this hyperechoic area and then the GB wall, and here you are able to see dense shadowing. So this is called WES or wall echo shadow complex, which is classic of chronic calculus cholecystitis. Okay. Now this is again a VIP question if you know it. Emphysematous cholecystitis, a very important question which can be clubbed, that is radiology and medicine can be clubbed using this. This is classically seen in diabetic patient. As the name suggests, what do you mean by emphysematous cholecystitis? You will see air within GB wall, which is called as intramural air in GB. So if this is GB and this is wall of GB, you will see there will be air foci within the GB wall. Okay. So now let us identify the investigations and let us see how does this appear on various investigations. Okay. So look here, this is USG image. You're not able to see the GB well. So remember, air is the enemy of ultrasound. Whenever there is lot of air, you won't be able to see the things well on ultrasound. Now mind well, this statement will help you to tell lot many investigations. What is the investigation of choice? So wherever there is pneumoperitoneum, the investigation of choice cannot be ultrasound because air is the enemy of ultrasound. So to diagnose minimal pneumoperitoneum, the investigation of choice would be CT scan. Okay, okay, and not ultrasound. So here you are able to see this multiple hyperechoic areas, but they are not showing full shadow. They are showing multiple artifacts. This is called reverberation artifact. So again, this is an important question which is asked on physics of ultrasound. What artifact is shown by air foci? Answer is reverberation artifact. Okay. Now on X-ray, you are able to see that there is a foci of air within the wall of GB, but it is very dicey. So you need to do a CT scan. On CT image, you can clearly see that within the GB wall, there are multiple air foci. Now, how do you identify air? On CT, air is dark, just like X-ray. So normally the soft tissue should have this density. Okay, it should have this density. Now here it is very dark. That means there is air within the GB wall, which is abnormal, and you have to diagnose this as emphysematous cholecystitis. It's an emergency condition, very commonly seen with diabetic population, and most important thing, this can be painless, surprising, but patient will have signs of sepsis. Okay. Okay. Now we come to an important another modality of imaging, which is MRCP. Now this is a very important and there are lots of questions which are asked on this. MRCP stands for magnetic resonance cholangiopancreatography. Now what is it? VVIP statement, very important statement. These are heavily T2 weighted sequences. Very important. This has been asked almost so many times uh, exams. Okay, it's a heavily T2 weighted sequence, very important statement. And so what will you see? All fluid filled structures would be very high in signal intensity. So this is basically MRI imaging, heavy T2 weighted images, fluid filled structures will show high intensity. Third important point. Fourth important thing which you should remember is that, so which are the fluid filled structures in hepatobiliary imaging? Of course, the gallbladder and the biliary tract. So the biliary tract, the gallbladder, the pancreatic duct in MRCP would be very well seen using highly T2 weighted imaging. Now, a very important point which I would like you to note is this. It's a non-invasive technique and there is no need of external contrast. Write down this in caps. VIP statement. There is no external contrast which is given. There is no invasive technique. It's a non-invasive technique. So why is this thing important? Because there is another technique of imaging which is called ERCP. Now ERCP is endoscopic retrograde cholangiopancreatography. As the name suggests, it's endoscopic. So we'll have to use an endoscope and we'll have to put an endoscope via oral route in order to do ERCP, whereas in case of MRCP, no need of endoscope, okay, and no need of external contrast. But in case of ERCP, we have to put an endoscope and then you have to cannulate the area and then you have to put contrast and then the image is taken. So now this is how MRCP images look. So now let us see those images and I'll discuss the important pathologies too. So here you are able to see these biliary radicals, the right hepatic duct, the left hepatic duct, the common hepatic duct, and here this is GB. So all the fluid filled structure, very important, they are bright on MRCP. It's a T2 weighted imaging, very important, okay. And now can you see this filling defects within gallbladder? So this is how cholelithiasis is seen. Cholelithiasis is seen as filling defect within GB. Important question. In GB. So that means this patient has cholelithiasis. Now here, this is CBD. This is CBD. And then CBD opens in the duodenum. So this is duodenum. Okay. Now that is why I have discussed the basic anatomy first, so that it is very easy to pick up the imaging anatomy. Now here, can you see a small filling defect here in CBD? Yes. So when you see a calculi in CBD, what is it called? This is choledocholithiasis. So there is choledocholithiasis. Cholelithiasis with choledocholithiasis. Now a VIP question. What is the investigation of choice for cholelithiasis? Answer was ultrasound. What is the investigation of choice for choledocholithiasis? Answer is MRC. So MRCP is the investigation of choice for choledocholithiasis. Now let us move ahead. Now I want you to identify the pathology which is seen and also identify what investigation this is. So yes, you are correct. This is MRCP. You are clearly seeing the ducts which are bright. So fluid filled structure which is bright. Okay. Here you, okay. So here you are able to see that there is a filling defect within GB, within the CBD. So this is a case of choledocholithiasis. Okay. Now this was a question which was asked in recent exams. Okay. Just last years this was asked. So now if you see here, this is an MRCP image because fluid filled structures are bright. And here you are able to see. So the question was, if the MRCP image is given and you have to tell what disease is associated with the pathology shown in the image below. So here you are able to see, if you compare it with the previous image where you are able to see that the hepatic ducts are so smooth, here if you look at the image carefully, you will be able to see such appearance. If you see the duct will go and then there will be narrowing. Again the duct will be dilated. Again there will be narrowing. Again the duct is dilated. Again there is narrowing. Somewhere again it is dilated. Somewhere again there is narrowing. So can you see this? See, here the duct is dilated. Here again you can see that there is dilatation, then again narrowing. Similarly, in this area you can see narrowing with dilatation. You can see the dilated part and the narrowed part. So this is called beaded appearance. Beaded appearance. Beaded appearance of biliary tract is classically seen in primary sclerosing cholangitis. Cholangitis. Note it down. VIP question. Very important. Now I will tell you a beautiful medicine question which is asked from this. Primary sclerosing cholangitis is an autoimmune disease, but it is more common in male than female. Very important question. Most of the autoimmune diseases are common in female, but this is one autoimmune disease which is more common in male. Now, another very important question which is asked is primary sclerosing cholangitis is associated with, now this was a recently asked question, it is associated with ulcerative colitis in 70% of cases. Ulcerative colitis, very important. Okay, very important. So, primary sclerosing cholangitis is associated with ulcerative colitis. Another important association in case of some patient, it is seen associated with scleroderma. Okay, scleroderma, but that is in some patient. Okay, now ERCP. So, as the name suggests, this is endoscopic. Okay, this is not MR imaging. So, you have to insert an endoscope, you have to get till the major duodenal papilla, then you have to put a side port, and then through that you have to put dye inside and image the pancreatico-biliary system retrogradely, that is from down towards the liver, and that is why this is called retrograde cholangiopancreaticography. Okay, and very important when it comes to ERCP, remember that in this contrast is used. Contrast is used. Next important thing is that this is invasive. But an added advantage of ERCP is that this can be both diagnostic as well as therapeutic. So there are many things which can be done with the help of ERCP. Even you can take breast biopsy from that area. So suppose there is a mass in this region, periampullary CA, and if you go there, as we have taken endoscope there, we can take breast biopsy from there, which is possible in case of ERCP, but this is not possible in case of MRCP. Okay, now let us move ahead. So this is how ERCP image is seen. Many of the times in NEET exams, you get direct question that identify what investigation this is. So I will tell you the trick to identify this. So let us see this. So here you are able to see this is a very bright structure which is seen on this film. So this is nothing but endoscope. So to identify ERCP image, which is the first thing you have to identify, the foremost, endoscope. If you identify endoscope, work is done. There is no other investigation in which you use endoscope. There is only one investigation, that is ERCP. Okay, in case of biliary imaging. Okay, now here you see That endoscope is inserted and you have put the dye, and here we are able to see the CBD, the right and the left hepatic ducts, and also here you are able to see the pancreatic duct. Okay, that's why it's called retrograde cholangiopancreaticography. Okay, yeah, hope that clears up the thing. Now let us move to another very similar looking investigation. Now this is a VIP question which was again recently asked in exam. Very important. Now here, are you able to see an endoscope? Answer is no, there is no endoscope. But here you are able to see something special. Try to look for. So here you are able to see that there is a special tube here which goes like this, and it has got a T end here. So this is called T tube. This is a T tube, and we have pushed the dye through this. So contrast is pushed through T tube, and there is opacification of the biliary system. So this is called T tube cholangiography. Very important, routinely pancreas, the pancreatic duct will not be seen with T tube. It is mainly cholangiography. It is not cholangiopancreaticography. Very important. Remember this. Okay. Chalo. Now let us move ahead. Now here is a beautiful question for you. Let us go part by part. So I'll tell you the history of the patient. So 52 years old female presented with constipation, and initially she had pain in right hypochondriac region, and imaging was done, and image is shown below. What do you think is the diagnosis? Now let us see, this is a beautiful case. So let us identify what's imaging modality is this. You are able to see this is a axial section, so this is sectional imaging, and you are able to see the bones are all bright, correct? So this is CT imaging. So this is axial section of CT, and this is coronal section of CT. Okay, coronal section of abdominal CT. And what are we able to see? We are able to see that the bowel loops are dilated. The bowel loops are dilated. So dilated bowel loops, number one, you are able to see dilated bowel loops. Dilated bowels. Now, second important thing which you are able to see is the stones within the lumen. Are you able to see this? There are stones within the lumen. So these are stones within the lumen of bowel. And the third important thing which I would like you to pick up is this. There is air within the GB. This is called pneumobilia. Now this three, so if there is dilated loops, stones within bowel, normally these are gallstones which come up from the gallbladder, and you see that there is formation of air within the biliary tract. This is called pneumobilia. This is classic Rigler's triad. Rigler's triad. And this is classically seen in gallstone ileus. So again, this question can be clubbed up with surgery and can be asked in biliary imaging. Okay. Now, a question which I would like to discuss on pancreatic imaging, a very important concept. 32 years old, presents with epigastric pain. What is true regarding the imaging study which is shown below? So let us see the imaging study. There is a section which is shown, which is showing you just the area of pancreas with dilated duct and multiple diverticulae like appearances arising from the duct. Okay, so this fluid is bright, right? So this is a case of MRCP. So this is MRCP sequence of MRI, and here you are able to see a special appearance which is called chain of lakes appearance in the pancreas, which is classically seen in case of chronic pancreatitis. Chronic pancreatitis. So here you have, this is an MRCP image which is showing chronic pancreatitis. Now this is the last image for today, and interesting. Let us first identify, let us first use what we have studied. So it's a cross-sectional image, so either CT or MR. Now look at the bones. Bones are bright, the ribs are bright. This is air in the lung which is dark. So this is CT image. What type of CT it is? So now look at the aorta. How is the aorta? Aorta is also bright. That means this is contrast CT. So this is contrast CT, or we call it CECT. That is contrast enhanced CT scan. And now here is the liver, and within liver you are able to see multiple fluid density, hypodense, cystic lesions. You are able to see them, they are multiple, and a very particular thing about this lesion is this central vessel which you are able to see in each of this. Right? This is called central dot sign. This is called central dot sign. Central dot sign is a very important sign which is seen in Caroli's disease. Caroli's disease. Now, what is Caroli's disease? Type 5 choledochal cyst. Okay, as per Todani's classification. Okay, so this is the central dot sign. What does the central dot represent in patient with Caroli? Again, an important question. They represent portal radicals. That is portal vein radicals. Okay, in patient with Caroli's disease. Very important question. Okay, now whatever we have done till now, we'll summarize everything whatever we have seen, and it will take you less than a minute to summarize everything. So let us start. Gallstones. Investigation of choice for gallstones is ultrasound, and they show classic posterior acoustic shadowing. Very important. CBD stone. What is the investigation of choice? MRCP. They give a specific appearance which is called meniscus appearance. Adenomyomatosis of GB. The artifact which is seen is comet tail artifact. Important. GB polyps, they do not change their position on moving patient. Very important. So they are stationary and they do not give posterior acoustic shadowing. Wall echo shadow complex is seen with chronic calculus cholecystitis. Very important question. Emphysematous cholecystitis. What is the most important thing? Patient would be diabetic. And the second important radiological finding, which is patient would have intramural air within GB. MRCP, most important things which you are supposed to remember, it's heavily T2 weighted imaging. Fluid is bright. So all biliary structures are bright and no contrast is used. Beaded appearance in biliary tree, primary sclerosing cholangitis, associated with ulcerative colitis. Chain of lake appearance on MRCP, chronic pancreatitis. Important question. Regular triad consists of paralytic ileus. You have got gallstones in small bowel, and you have got pneumobilia, that is called gallstone ileus. Now, Caroli's disease, central dot sign. Acute cholecystitis, HIDA scan is the best investigation. GB is not seen in patients with acute cholecystitis on HIDA scan. Now, that was great delivering you this session. I hope you have enjoyed this session, and this session will help you out a lot with your NEET exams. Thank you.